Today's topic is transfusion transmitted infections. The learning objectives are to enumerate the different infections transmitted through blood transfusion and enumerating the diseases tested for before transfusion and the methods of testing for those diseases. Blood transfusion. The blood transfusion is a life-saving intervention that has an essential role in patient management within the healthcare systems. The establishment of systems to ensure that all the donated blood is screened for the transfusion transmissible infections is a core component of every national blood program. There have been major developments in the screening for the transfusion transmissible infections with the identification of new infectious agents and improvement in the detection of markers of infection in the donated blood. There are three basic conditions that will determine whether an infectious agent is likely to be transmitted by the blood transfusion. First is, the agent must be capable of using the bloodstream as the route of entry in the host. Second, the infected donor must be free of any signs and symptoms of the disease. Otherwise, they would have been identified during the donor screening and the donor would have been excluded or deferred. Third, the agent must exist naturally for a period of time in the bloodstream of an infected donor. In the transfusion transmitted infections, they are categorized broadly in two types. They are the exogenous and the endogenous. Exogenous, as the name suggests, are the infections, those which are introduced into a blood unit from an external source. And endogenous, they are the infections, those already present in the donor. Now we'll classify the different types of infections that are present in the blood as the cell-associated viruses. There is the cytomegalovirus, EBV, HTLV 1 and 2, herpes simplex virus 1 and 2. The plasma-associated viruses are the hepatitis B, C, A, D virus, human immunodeficiency virus, it is HIV 1 and 2, and human parvovirus. The bacteria the Treponema pallidum, Brucella abortus, Yersinia enterocolitica, and Salmonella. The protozoa that can be transmitted through blood are Plasmodium species, which cause malaria, the Trypanosoma cruzi, Microfilaria, Toxoplasma gondii, Leishmania donovani, and the Babesia microti. Those which show the asterisk, they are infrequently reported in our country. The characteristics of the transfusion transmissible infections. All these infections, they have one or more window period that range from a few days to months, depending on the infectious agents. So the screening markers used and the screening technology employed. And during this window period, that particular screening marker is not detectable in the recently infected individual, though the individual may be infectious during the screening process while donating the blood. And the nucleic acid, which is a part of the native infectious agent itself, is the first detectable target to appear, followed within a few days by antigen and subsequently by antibody as the immune response develops. So for detection, the markers are first the nucleic acid, then the antigen, and then the antibody. Now coming to the infections which we'll study here that are transmissible and are screened for are the hepatitis B, hepatitis C, HIV, the malarial parasites, and syphilis. HIV. The human immunodeficiency virus is a retrovirus enveloped RNA virus. There are two major distinct virus types, that are HIV-1 and HIV-2, reported in our country. The virus is found in the blood and other body fluids. It is stable at the temperatures at which the blood and individual blood components are stored. Transmissible by the parenteral route. The infectivity, the transfusion infection infectivity is much higher, around 95%, than for other modes of HIV transmission. owing to the much larger viral dose per exposure than for the other routes. Once in the bloodstream, the virus primarily infects and replicates in the lymphocytes. The viral nucleic acid persists by integrating into the host cell DNA. HIV screening. The antibody may be detected approximately 3 weeks after the infection and approximately 6 days after the antigen is first detected. The antigen, that is the HIV P24 antigen, appears 3 to 10 days after the viral RNA is detected. This viral RNA can be detected approximately 7 to 11 days after infection. That is the time when the results of antigen and antibody assays are negative. Okay, but that the HIV RNA detection is positive. The detection of HIV RNA can reduce the risk of HIV transmission during the serological window period of antigen antibody assay. So the main tests which we'll do are the antigen test and the antibody test using the immunoassay, that is enzyme immunoassay, and the chemiluminescence, or the rapid assay, which can be performed in small laboratories with small throughput and in remote areas or the emergency situations. Here we are just given a simple tabular form. Like for HIV virus, the screening marker are the antibodies for HIV. The assay will be immunoassay, enzyme immunoassay, and chemiluminescence. They are essential for effective HIV screening, and the specific detection of antibodies to both HIV-1 and HIV-2 is essential. The rapid immunoassay or the particle agglutination, they are used in special situations or in the small laboratories. Then HIV P24 antigen, the method is enzyme immunoassay and the chemiluminescence, which is recommended as part of the combination antigen antibody assay. So combination of both the tests gives a most specific and sensitive result. It is the first serological marker of HIV infection and can be detected at the same time or very soon after the first detection of HIV RNA. The HIV RNA, is detected using the nucleic acid amplification technology, the NAT, but we have to evaluate the safety versus the cost and logistics because the test is very costly. It is the first circulating marker of HIV infection, but the window between the detection of HIV RNA and HIV P24 antigen may be very short. So it's advisable to go for the antigen test. Then coming to hepatitis infection, they're classified like this: HIV, hepatitis B, hepatitis C, and others which we will not discuss over here are hepatitis D, hepatitis A, and hepatitis E. Hepatitis B virus. Hepatitis B virus, that is HBV, is a member of the hepatna group and is an enveloped DNA virus. It was transmissible by the parenteral route and may be found in blood and other body fluids. Once in the bloodstream, the virus travels to the liver where it replicates in the hepatocytes. The incubation period on an average is around 59 days, that is 5 to 12 weeks, and it may be as long as 6 months also. Viral titers of HBV in the blood are much higher than those found in the semen, vaginal fluid, and saliva. Infectivity: the HBV is 100 times more infective than HIV, and HBV is 10 times more infective than HCV. The hepatitis B surface antigen is detectable in the blood approximately 4 weeks after the infection. Hepatitis B virus screening. Hepatitis B surface antigen, we call the HBsAg, is the prime marker used in the blood screening programs. It normally appears within 3 weeks after the first appearance of HBV DNA and the levels rise rapidly. The antibody to hepatitis B core antigen, that is anti-HBc, is produced later in the acute infection after the appearance of HBsAg, and that marks the start of the immune response to HBV infection. In general, anti-HBc persists for life irrespective of whether the infection resolves or the progresses to the chronicity. So for screening, the following serological markers are tested. That is the hepatitis B surface antigen, hepatitis B core antibody in some situations, and the viral nucleic acid HBV DNA. Again in the tabular form, we'll study as the screening marker HBsAg tested using the enzyme immunoassay and the chemiluminescence. It is a recommended test because the first serological marker of HBV infection, and it is essential for effective screening. Because screening of HBsAg is recommended as a minimum standard for the blood safety. When it is done by the rapid test or the particle agglutination, this test may be used in special situations in small laboratories. Now, anti-HBC, that is enzyme immunoassay and the chemiluminescence methods are used. It is not recommended, especially in countries with high HBV prevalence. The assay may lack the specificity and specific conformation is not available. The most sensitive test is the HBV DNA. There is a nucleic acid amplification technology used. Again, it's very costly. As for its points, the first circulating marker of HBV infection, but it is of limited usefulness in the blood screening unless individual donation testing is performed. The virus is generally low titer and the window period between the detection of HBV DNA and HBsAg is generally very short. So it's advisable to get the HBsAg is the most recommended test, antigen test. The hepatitis C virus. Hepatitis C virus is a member of the Flavi group and is an enveloped RNA virus. It is transmissible by the parenteral route and may be found in blood and other body fluids. Once in the bloodstream, the virus travels to the liver where it replicates in hepatocytes, resulting in a similar picture to that seen with the HBV infection. For the screening of hepatitis C virus, 75 to 80% of the HCV infection progresses to chronic infection, and of these, 10 to 20% may progress to cirrhosis or the hepatocellular carcinoma. The average incubation period is 6 to 7 weeks. The HCV transmission is primarily from the percutaneous exposures. 2/3 of those infected have a history of injection and the drug use. Approximately 15% have received transfusion before blood donor testing started in 1990. After that, because of the use of these screening tests, the incidence has decreased a lot. The serological markers which are tested are the HCV antibody, HCV antigen, the viral nucleic acid, that is HCV dRNA. Anti-HCV, that is the antibody for HCV, they are tested using enzyme immunoassay and chemiluminescence. Currently, there is the most commonly used serological marker of HCV infection. It can be done with a rapid test also in the special situation in small laboratories. Then the antigen testing for HCV tested using enzyme immunoassay and chemiluminescence, recommended only if as part of the antigen antibody assay. The antigen, like we saw in the previous discussion, is the first serological marker of the infection. The screening of the antigen only is not appropriate as the levels fall when the antibody levels rise. So, the antigen and antibody, they can be done in a combination. The most sensitive HCV serological assay combine both testing the antigen and antibody. It is considered most effective for the serological screening of donations. Third is the HCV RNA, the nucleic acid amplification technology used. It's very costly. The RNA, it is the first circulating marker of HCV infection, but the window between the detection of RNA and the antigen may be very short. The screening of RNA has been implemented in a number of countries only for the safety of plasma for fractionation. Value of the screening is related to serological screening performed and the incidence of infection in donors. So the best recommended test in the screening in the blood banks are the anti-SAV. Syphilis. The serological tests for syphilis were introduced for the blood screening in the US in 1938 and were required by the regulation in 1958. The Treponema pallidum spirochete causes syphilis. The Treponema pallidum can be transmitted by fresh blood and platelets. The incubation period of the transfusion syphilis is 4 weeks to 4 to 5 months. The Treponema pallidum may be found in bloodstream. Levels are variable even in acute primary syphilis, and the bacteremia is often short-lived. The treponemas are relatively fragile, in particular being heat sensitive. So the storage below 20 degrees Celsius for more than 72 hours results in irreparable damage to the organism such that it is no longer infectious. Blood components stored at higher temperature, that is above 20 degree, such as the platelet concentrates, or those not stored at lower temperature for any length of time, such as blood collected and used within 48 hours, present a significantly higher risk of transmitting syphilis. Thus, though clearly potentially infectious, the risk of transmission through the transfusion of blood and blood components stored below 20 degrees Celsius is very low. Screening for the donated blood for the transfusion transmissible infectious is nonetheless very essential. The antibody to Treponema pallidum tested using the particle agglutination test or the immunoassay. It is the first serological marker. The antibody testing is the first serological marker of syphilis infection, both the recent infection and the past infection, whether it is treated or not treated. Screening for the antibody is recommended as a minimum standard for the blood safety. And other is the antibody to the lipoidal antigen. The test using the test VDRL and Venereal Disease Research Laboratory test and the RPR, that is a rapid plasma reagent test. It is considered when there is high incidence of syphilis. They are the first serological markers of syphilis infection, but they do not detect the syphilis specific antibody. They lack the sensitivity and specificity, and it detects only the recent infection. Last, we'll discuss about malaria. India is considered as to be an endemic zone for malaria. There are the four species of Plasmodium, that is the Plasmodium falciparum, Vivax ovale, and malaria. In India, the most malarial infections are caused by P. falciparum and P. vivax. Viability of the malarial parasites in red blood cells is stored at 4 degrees Celsius and in platelet concentrates stored at room temperature and following the cryopreservation and thawing of the red blood cells. It remains viable in stored blood for up to 1 week. The P. falciparum remains viable in stored blood up to 2 to 3 weeks. Malaria can be transmitted by a red cell or any blood component containing even small number of red cells. As few as 10 parasites can cause Plasmodium vivax malaria. The screening. The incubation period ranges from 7 to 50 days with an average of 20 days for the P. falciparum and P. vivax. The incubation period depends upon the number and strain of the Plasmodium transfused, the host factors, and the use of antimalarial prophylaxis. The screening methods employed are for the direct detection of the parasite using a blood thick film and the serological markers for the antigen and antibody. Apart from all these infectious agents, there are other chances of bacterial contamination. The bacterial contamination of the red cell and platelet component is the second most frequent cause of transfusion related fatalities reported to the FDA. Bacteria enters the blood containers as a result of inadequate skin disinfection at the phlebotomy site. The transient bacteremia concurrent with the blood donation, or a break-in technique during the pulling or sealing, or through the disruption of the container integrity. The bacterial proliferation occurs more rapidly in the platelet concentrates stored for up to 5 days at room temperature than in the red cells stored for up to 42 days at the refrigerated temperatures. The microorganisms isolated from the contaminated red cell units include Staphylococcus epidermidis, Pseudomonas, and Yersinia enterocolitica. The most fatal reactions are due to the endotoxin reactions associated with the gram-negative bacteria. The methods of testing for all these infections, which we had just mentioned, the test like the enzyme immunoassay, rapid test. So we'll just again do the brief learning of all these tests. There are the two types, the immunoassay and the nucleic acid assay. The immunoassay are again categorized as the enzyme immunoassay, chemiluminescent immunoassay, heme agglutination, and the particle agglutination assay, rapid or the simple single-use assay. And the other is the nucleic acid amplification technology. The enzyme immunoassay and chemiluminescent immunoassay are the most commonly assays for the screening donated blood for the transfusion transmissible disease. They are suitable for the screening of large number of samples. These tests require a range of specific equipment and are performed either manually or on an automated system. The automated system may be again an open system or a closed assay performing system. The particle agglutination assay, they detect the presence of specific antibody or antigen in a test sample through the agglutination of particles, which are coated with the complementary specific antigen or antibody respectively. Agglutination assay, mainly the antibody assay, use a range of particles including red cells, so that is the heme agglutination, and inert particles such as gelatin and latex. The basic principle of both the heme agglutination and particle agglutination are the same, irrespective of the type of the particles used. The particle agglutination assay are extensively used for the detection of syphilis antibodies. The rapid test or the simple single-use assay, they are discrete individual disposable assays, means they are used once and discarded. The principle, it is based on a form of immunochromatography in which the added sample flows down an inert strip and it reacts with the previously immobilized reagents. The sample used can be the serum, plasma, or even whole blood in some cases. Any positive reaction is visualized as a dot or a band appearing on the device strip. Most of the assays include a control dot or band that is used to validate the result of each individual device, irrespective of the specific test result. The results are read visually and they give a simple qualitative result within minutes. So in small laboratories, the rapid tests are very prevalent. The nucleic acid amplification technology assay, we call NAT, is applied to the blood screening. It detects the presence of viral nucleic acid DNA or RNA in the donation samples. In this technology, a specific RNA or the DNA segment of the virus is targeted and amplified in vitro. The amplification step enables the detection of very low levels of virus in the original sample by increasing the amount of a specific target present to a level which is easily detectable. The presence of specific nucleic acid indicates the presence of the virus itself and that the donated blood is likely to be infectious. This is a very sensitive test, but again, it's very costly. So to summarize, the transfusion of any blood unit is always associated with inherent risk of transmission of the bloodborne infections. The stringent donation selection by medical history, travel history to any endemic zone for malaria and all those, the physical examination, exclusion of donors with high risk behavior, and donor education have immense role to play in preventing the transmission of transfusion associated infections. Once blood is donated, it has to be followed by performing all the screening tests for the transfusion transmitted infections as per the guidelines of the blood bank. Thank you.